Hey guys, my name is Paige Walker and I'm a paramedic for Catawba County EMS. I have been with Catawba for about 4 years now. I love working there. It's a great place to work for, a great environment, and I also love taking care of patients. So I love overall what I do. I'm really excited to expand and become an instructor and share knowledge and hopefully help other people become paramedics and love the field as much as I do. So today I'm going to be teaching you guys about the 7 P's of RSI. This might be something you've already learned or heard about, so if it is, great. Hopefully I'm going to teach you something new or something you forgot. And if it's new to you, that's okay. Hopefully you'll take away a big part of this. So if you have any questions as we go along, feel free to ask, or if there's anything you want to add to it that maybe I left out or something that you've learned previously, let me know. So just let us, that might share with everybody else and help somebody learn something new, okay? So RSI is rapid sequence induction or intubation, people call it both. And can anybody tell me when we need to RSI our patient? Yeah, so failure to protect their airway, okay? That's a huge thing. So they might still be awake and might still have their gag reflex, but they're still not protecting their own airway, so that's where we need to take over. Like I said, if you have questions, ask them now. In the field is not the time to be asking questions or learning about RSI, so ask now. Another reason is unable to ventilate for whatever reason. So today's class is going to be geared towards trauma patients. So unable to ventilate and unable to oxygenate. Maybe they have facial trauma. Maybe they have a deviated trachea. Maybe they have a big old beard and we're not able to get a good seal on bagging them. So there's a lot of different reasons of why we can't oxygenate and ventilate the patient. Okay, is there an obstruction somewhere? There's a lot of different reasons, like I said. So we're going to talk about that today. Also, impending airway compromise. Okay, trauma patients are big for that. Do we feel like they're going to lose their airway or it's going to be compromised soon, right? Trauma, respiratory patients. Those are big. And then some objective signs that your patient has impending airway compromise would be agitation. Did you talk to them 5 minutes ago when you assessed them and they were normal or appeared to be what you thought was normal, and now they're getting very agitated and saying things that they weren't saying before, maybe even a little combative? Okay? Are they getting cyanotic? That's a huge sign that they're obviously not perfusing well. They're not oxygenating themselves. Something's probably about to happen that's not good, that we need to protect their airway ourselves. Another thing is abnormal breathing. Are they making high-pitched noises, like air's not getting through their trachea? Like maybe they have swelling or something's in there. And then the deviated trachea, that's another thing. So that is the beginning of the RSI and why that's our why, so why we would need to do it. Let's get started on our P's. Anybody know the first one? Yep, so preparation. Preparation is huge. This is not an event where you need to be searching through your bag or asking your first responder to grab you something you forgot. So you've got a partner, more than likely in a situation like this, hopefully you have first responders on scene. So you should have plenty of hands to help out, organize it, delegate, okay? So prepare. You need to monitor vital signs. Big things is your pulse oximetry. Pulse oximetry is going to give you your oxygen saturation as well as your heart rate, okay? So you need to pay attention to that. Sometimes it's not always reliable or 100% accurate. You might get numbers that are a little variant of what they actually are, depending on if the patient has fingernail polish or however. But still, it is a number and we need to pay attention to it, okay? Heart rate. Heart rate's going to tell us a lot. Is it going up or is it going down? Are they compensating? Another vital sign is blood pressure. Blood pressure is the same way. Is it increasing or decreasing? Is it decreasing because they're losing volume somewhere? Are they bleeding? Or is it because they might have some kind of intracranial hemorrhage, so their ICP is going up? What is the reason for that heart rate and blood pressure shifting? And then another thing is the cardiac rhythm. Yes, we're paying attention to the rate, but we need to pay attention to the rhythm. Are they in some kind of abnormal rhythm because of the trauma, or is this a cardiac event that caused them to have a car accident, and now there's the trauma due to the car accident, but the underlying issue was the cardiac event? So the rhythm's very important. It could possibly tell us why we're here, or it could tell us what is about to happen because of the trauma. So we need to pay attention to that. Also, when we do this RSI, some of these medications might alter these patients, so their vital signs tend to change. So we need to pay attention to those changes. Are they safe changes, or are they changes where we need to intervene because they're dangerous? Another thing is your IV. We need at least one patent IV. Most definitely, you gotta have one, because you're gonna be pushing medications through the IV. But preferably, we need two. Two's huge. What happens if that one fails you? Now you have no backup. So we need two if at all possible. I know that some people are hard sticks, or if they're losing volume, their veins are shutting down, they might blow, but we need two if at all possible, okay? And then the next big part of preparation is equipment. It's really important to have our equipment ready to go. Make sure it's functioning, make sure it's there. Make sure we didn't leave it on our last call, right? That's terrible. So BVM, you need that. And then a yonker. Why do we need a yonker? Well, we're going to need to suction possibly. Did they vomit in their airway? Do we need to suction out their mouth? Is there blood in their airway? That's huge for trauma patients. Expect blood most of the time. And then end-tidal CO2 detector capnography. Okay, we need to monitor that capnography waveform, but we need to make sure that this is the tube end-tidal, not the nasal cannula. So I know in Catawba we carry both. We need to make sure that we have the one that's appropriate for the ET tube. And then we need a functioning laryngoscope with the blade of choice. So you've got your Mac and your Miller, and you have different sizes. So whichever you choose appropriate for your patient, Mac or Miller, based off of your preference. But we need to make sure that it's functioning. So by functioning, we should have checked it off this morning, but maybe we got that early morning call and it just didn't happen. It happens. So we need to make sure that we have a functioning blade. Okay, functioning laryngoscope. So pop that blade on, pull it out. We need to make sure that the bulb is screwed in tight and that the light's working. Make sure everything's there, nothing's loose, nothing's missing, okay? And then we need an endotracheal tube an appropriate size. They say on average that men are 8, women are 7. Is that always accurate? No, that's right, it's not. So you need to gauge off of your patient. There are different ways to tell that. And then best practice is to have different sizes. So you need one above and one below. You don't have to open them, but you've got your partner there. So if something doesn't work out with that first one, you've got one to back up, okay? So if we have a failed intubation, what do? We change something. It might be the size of your tube that we need to change. So it's always best just to have it there and ready, okay? We don't have to open it, just have the package there. And then all of our RSI medications, we need all of them. All of them we're potentially going to use. We need them, and we need them ready to be administered. So that means we need them drawn up. So we need our syringes. We need our needles to draw up with. We need all of that. It needs to be ready. And then we need to draw up those medications appropriate for the patient weight. So our medications are based off of kilograms. So we need to make sure that we have a semi-accurate weight. We're guesstimating. So we need to make sure that we're as close as we can be for our patient weight. And then we need to go ahead and draw up those medications, right? Because we need them labeled so that they're there and we know what they are and that person is responsible for them who drew them up. So we need to check all of those, our 5 rights, and then make sure they're ready to go, even if we don't use them. But once you start and you finish that first medication, you're finishing it to the end, right? Yeah. And then we need to assess for possible difficult airway. So this one's a little tricky sometimes because who's heard the mnemonic lemon? Yeah, we've used lemon before. So does anybody tell me what the L is? So look externally, we're going to look at them. Do we see the trauma? Do we see that they're difficult? Do we see that they've got that big old beard we talked about that we're not going to get a good seal on? Okay? And then we evaluate. So we're going to evaluate. You may have heard of the 3-3-2. Okay? So 3, we're going to take 3 fingers and see if they fit in their mouth. Okay? And then you're going to take 3 fingers and you're going to go from the tip of the chin to the hyoid bone. You got 3 there. You're good. And then the 2, we're going to take 2 fingers and go from the hyoid bone to the thyroid cartilage. You should get 2 fingers there. So if you don't get 2 fingers there, that could tell you that they have an anterior larynx, so they could be a difficult intubation if they're really anterior. Are you going to be able to stick your fingers in an unconscious patient's mouth? No. So the 3-3-2 is more of like a preoperative for people who have opted for surgery. That's something that anesthesia can do with them. However, it is something that we're still taught, but you're not going to be able to do that for your unconscious patient. So that is part of the evaluation. And the M, what's the M? So Mallampati. Mallampati, who's heard of Mallampati? They also use that in preoperative. You're not going to be able to do this on your unconscious patient. Typically, it's not going to work out. So like I said, in this rapid sequence induction, this is not typical that you're going to be able to do the evaluate with the 3-3-2 or the Mallampati, but we'll go through it. So Mallampati, you have 4 classes. Class 1, that's where you completely visualize the soft palate. Okay, so when you open their mouth up, you're seeing that soft palate, nice and pretty, the whole thing. A class 2 is where you completely visualize the uvula. So just a little bit less of a view, but you're still seeing it. And then class 3 is where you are only seeing the base of the tongue. So now we're getting closed off, okay? And then class 4, you're not seeing anything. You're not visualizing anything. Soft palate is not visible at all. So there's that. And then we go on for O. O is obstruction. So is there something obstructing their airway, or are they having airway compromise? Are they swelling? And that's the obstruction. So we need to think about those things. And then N. N is neck mobility. Do they have something like kyphosis? Or do they have a C-collar on because it's trauma? So we need to think, is their neck mobile to move? Are we going to be able to maneuver them? Okay? Because if they're in a C-collar, how much are we moving them? Not a lot. Yeah, they're stiff. So we have to think about those things as well. So that's your lemon. So that's what we're assessing for that difficult airway. Okay, so next P, our big one, it's pre-oxygenation. This is big for our patients. They're not oxygenating themselves, and if they are at all, we're getting ready to take that away from them completely. We need to make sure that we can do this before we start, because once those drugs are pushed, we've taken that away from them, and it's now all in our hands, right? Okay, so pre-oxygenation, we want to give them as much oxygen in the next 3 minutes that we can. So we want to give them 100% oxygen. We're using a BVM, or if that's not available for the moment, we can use a non-rebreather, but we want to give them 100% oxygen. We want to get that oxygen saturation up to 100 if we can. Because what's going to happen when we do our intubation? Yes, they're going to desaturate, and we want to make sure that it's not a lot, that it's still within something safe for them, oxygen level-wise. So we want to pre-oxygenate. That's huge. So So we want to spend, they say for a regular intubation, no more than 30 seconds each attempt, okay? So if you have to, you might have to reoxygenate your patient if you're dropping really low, but remember, we're going to be pushing medicines and things, so we need to make sure that we're really fast and accurate with this. So most of the time almost all the time, if available, you want your most experienced paramedic to be doing this, right? Yeah, so you want to make sure that the most experienced person is intubating, because we want to get that done on the first attempt, and we want to be fast with it, because we've pushed medications. Some medications that we might have on our trucks are not long acting. So we want to get this done as soon as possible, and we want to be able to oxygenate the patient again. So just remember, preparation, and then we're going to pre-oxygenate. Does anybody know what's next? Pre-treatment. Yeah, so we're going to pre-treat them. This is where we're starting to push those medications. So we'll talk about several medications. You might not have them at your agency. Some of them, maybe one of them, we use on the ambulance, but the treatment for it's kind of geared more towards maybe a hospital setting. So lidocaine, right? That is very one of the older drugs. It's not as commonly used as it used to be, and actually I've met a lot of newer paramedics that they're like, what's lidocaine? They didn't even really touch base on it much in school. So lidocaine, your dose is 1.5 milligrams per kilogram IV, but you need to pay attention to your agency specific rules, okay? So what does lidocaine do? It is going to reduce intracranial bronchospastic response. So those patients who have suspected increased ICP, intracranial pressure, this is going to hopefully help reduce that when you go in with the laryngoscope and you manipulate that airway. You trigger sometimes their ICP to increase. So that lidocaine is hopefully preventing that. Studies have shown that it's not beneficial. Studies have shown that it is. So it's kind of a back and forth. But for now, it is still used, okay? And then fentanyl, okay? Once again, all these drug doses are specific to your agency. You might have a different rule. So we're going with 3 micrograms per kilogram IV over 1 minute. And what does this do? Does anybody know? Okay, so it's going to reduce the sympathetic response, okay? So that increase in the heart rate and the blood pressure due to that intubation in patients with increased ICP or intracranial hemorrhage, aortic dissection, cardiac ischemia. So it's going to reduce that. Once again, those vital signs, those are really important that we're paying attention to that heart rate and that blood pressure, right? Alright, so vecuronium, right, 0.01 milligrams per kilogram, that's IV push. It blunts the ICP elevation caused by succinylcholine in patients with elevated ICP. Okay, so if you have vecuronium as your first choice instead of succinylcholine, and you think those patients have an increased ICP, why would you not use it first? Right? So you can, if that's in your protocol. But if you've pushed the succinylcholine and you've already, then you're starting to realize you're backpedaling that, I think they might have, increased ICP, and then you need to give the vecuronium. That's going to hopefully help blunt that, so it's going to cancel it out. And then this one, maybe not so much. This might be in your protocols or not, but it is said that atropine, it's not standard. It's not standard for treatment. However, it says consider. So if you might could get medical orders for this, but it's just something that they've done research on. Atropine. Consider pre-treatment with atropine in children under the age of 1. Okay, so peds become bradycardic during RSI, and that is due to, it's called reflex bradycardia, and that's due to the baroreceptor reflex. That's kind of our body's homeostatic way of preventing increase in blood pressure, so it's going to cause them to brady down. So that can kind of counteract that with atropine. However, you need to be very careful. So like I said, it's not a standard of care. but it's something that has been thrown out there to consider in peds. So that's just something we're just talking about. So just remember that's not a standard. And then, what about next? What are we going to do? Alright, so we just talked about our pre-treatment medications. So if we notice, most of those medications was because of increased ICP, right? So that's what we're pre-treating. That's our big pre-treatment. And then next, we're going to do what? So we've already pushed one treatment medicine. Are we going to go again? We are. We're going to paralyze. Alright? So we want to give one of the following induction agents, which would be a sedative. There's going to be rapid IV push prior to the paralytic. Why? Yeah, we want it rapid because a lot of them are short acting. When we push this fast, we want it to be active fast. So etomidate, okay, dose for that 0.3 milligrams per kilogram. And then we have ketamine. A lot of agencies are going to ketamine now. So we have ketamine in Catawba County. 1.5 milligrams per kilogram IV. And then there's the good old Versed, midazolam. We have 0.3 milligrams per kilogram IV. And then this one's more hospital-based. I don't know of anybody that carries propofol as far as like they're administering. I know we do on interfacility transfers we can carry, but propofol, and it's 1 to 2 milligrams per kilogram IV. But like I said, I don't know anybody that carries it. So those are our sedatives. Those are our pre-paralytic. So we want to push those fast, and then we want to have that paralytic ready to go. So once again, that goes back to our first P for preparation. We want to have all of those drugs drawn up, so we're ready to go. So we're going to rapid IV push one of the paralytics after the sedative, okay? So we're just going to use succinylcholine as an example. So 1.5 milligrams per kilogram IV, okay? So you've got your ketamine. Doses are the same, right? So if you can choose those, sometimes it's easier to remember 1.5 and 1.5. And if we had to give what other pre-treatment medication, it's the same dose. The lidocaine, 1.5. So, and then rocuronium, 1 milligram per kilogram IV. So that's easy, hopefully, to remember. So we're going to push those fast. So we've got preparation, pre-oxygenation, pre-treatment, paralyze. What's next? Protection. So we want to protect their airway, right? We're doing something to hopefully protect it definitively, but while we're doing this to intubate them, we want to protect their airway. Who's familiar with the Selleck maneuver? So you might know it as cricoid pressure, right? So it's also cricoid pressure. That's a lot of what we call it. That's what I called it. That's what I learned it as. But the appropriate term is Selleck maneuver. So that is firm pressure on that cricoid cartilage right there. And that's while maybe your partner's intubating, so you can push firmly on that. Sometimes it helps give them a better visualization of the cords so that they can pass that too. But also what it really does is it prevents gastric regurgitation. So it should be applied as soon as the consciousness lapses. So as soon as they're unconscious, and be maintained throughout the intubation until the tube's placed confirmly. So if you're going to use that, then we need to make sure that you do it the entire time, right? Okay. And we've kind of gone away from it. I haven't seen it used as much as I used to. So it is still practiced though. It is still a method. And it's a big part of the P for protection. Has anybody in here used it? Yeah. I feel like from my experience, people either think it's beneficial or they don't. There's some people who are big fans of it and use it every time. And then some people, you know, I would say that maybe some of the older paramedics, more experienced, have been there in the field for a while, are use it more often than the newer. And I think that's just difference in what was taught to them. Okay. All right. So our next big P It's going to be placement. Placement. Alright, so we are going to insert the ET tube with direct visualization of the vocal cords. Okay, so now we have these wonderful video laryngoscopes. King Vision is what Catawba has. You can use those on your first intubation if you want to. They let you. Okay, that's a great visualization, right? You've got that camera, somebody else can see it too. But what are other ways? Right, so there's nothing better than directly visualizing it going through the tubes. Direct visualization with your eyes, right? Okay, and then condensation in the tubes, another way for confirmation. Alright, so once we pass that tube through the vocal cords, we feel like it's there, we're very confident. We need to inflate that cuff, right? That 10 cc's, inflate that cuff. And then we need to confirm that it's in the trachea. What are we going to use? That's where that capnography comes in, that end title. So we got to get it out of our bag and we realize, oh gosh, it's the nasal cannula. Remember, that's why I said preparation is the key. It's where we double check our equipment, because now we're asking somebody to fumble for it, and we don't need to be doing that because we're needing to get this done. So we pull it out and it's capnography for the ET tube. So we place that on, we get it hooked up to our monitor, and we've got a beautiful wave for an intubated unconscious patient. So we need to auscultate. Where are we going to auscultate first? The epigastric region. So we want to make sure we're not in the stomach. Remember, we saw it go through the cords, but sometimes what we see and where it goes, maybe we pulled back on it. Maybe it dislodged that quick. Maybe we let go of the tube before we got it secured, right? So it happens. So we need to make sure it's not there though. So we're listening, there's absent epigastric sounds, and then where are we going? We're going to our lungs, right? So we're going to listen. Where do we most often intubate? If we're not getting equal chest rise and fall, where are we most often at? Yeah, the right. We're usually in the right. So sometimes that's as easy as just pulling back on the tube just a little bit, and we're right where we need to be. So it's not bad, but if you're right main stem, sometimes you can pull back and you'll be great, okay? You just went a little too deep. Then our next step, once we've confirmed that we're good, and what about if we're not good? What do we need to do? You gotta pull it. We need to pull it immediately. We don't leave it, okay? We need to pull it. And if sometimes, depending on what your patient has ate or drank, is on their stomach, sometimes we'll get a reading that's okay for our capnography waveform. So, we need to make sure that we're in there. So, securing the tube. It says with tape. Sometimes that's what you have. Most of us have commercial securing devices, that tube holder. So we need to make sure we're not letting go of that tube until that commercial device or tape or whatever you're securing it with is on there good. Because if we lose that tube, it's not going to be good. Okay? Because now you've got this patient who's paralyzed and sedated, their airway's completely gone, and this is their only way for oxygenation. So we want to secure it. And what else do we want to do when we do that? We want to document. So make sure we're marking exactly where that tube is at. If it's 22 at the lip or the teeth, people have different markers. Some people use the lips, some people use the teeth. I use the lips. I think it's what you prefer. But at this point, if you're still holding that cricoid pressure of the Stillip maneuver, you let go of that. You've got that tube in, you can let go, okay? So go back a minute to the pre-treatment. I want to talk about that for a minute, or the paralyzed, sorry. Go back to it for a minute. We're going to back. All right, so paralyzed. So guys, tell me something about succinyl choline for contraindications. Remember we talked about the VEC? Yeah. All right, so some contraindications for succinyl choline: malignant hyperthermia. Okay, hyperkalemia. So malignant hyperthermia, are you going to know that your patient has that? More than likely no, unless you've got family around. Situation of that's probably very low percentage that you're going to, but sometimes you do. So if you have somebody around and you're able to ask them, it's not something that would typically come to mind. They might even not know they have it. You're going to run into that. What population is high for that? So Lumbee Indians, okay, malignant hyperthermia. So people with muscular dystrophy or multiple sclerosis, those are also contraindications for succinylcholine. So, maybe they have an ID bracelet on that we can see. That's where we would get lucky. Otherwise, we're not going to know that's contraindicated. But those are contraindications, and I wanted to go over that. So let's go back. So we've got preparation, pre-oxygenation, pre-treatment, paralyze, protection. We've done placement. And now we're going to go over our post-innovation management. Okay, so I said earlier that some of these might be hospital instead of pre-hospital. So this first one that was on the list is something that they will more than likely do when they get in the hospital. They're going to do this. So what is it? A chest x-ray. So they're going to do a chest x-ray, and why? They're going to assess the placement. They want to confirm the placement of that ET tube. Now, when they do that chest x-ray, that ET tube should be, the tip of that tube should be at mid-trachea. That's the perfect spot. It's exactly where it needs to be. Okay, and then long-acting sedatives. And, if necessary, paralytics. So, if you're 30-35 minutes from the hospital out in a very rural area and you're not close to a hospital, you need to consider those. So if, example, lorazepam, vecuronium, those are long-acting. The lorazepam sedative, long-acting. The vecuronium, long-acting paralytic, okay? So we want to make sure that we're giving them something that's going to be sufficient. We do not want them waking back up, especially if they weren't able to protect their airway. We want to make sure we're doing that. And then post-intubation management, initiate mechanical ventilation, right? We're bagging them with the BVM. When we get them to the hospital, we're going to get them switched over to a ventilator. You're going to have your respiratory team there. When you do your call-in, you're going to notify them that you've got that intubated patient from that RSI. And you're going to let them know, right? You're going to let them know what you've given them. If you're able to have time, can do that quickly and efficiently. And you're going to let them know their status. So going back to that, the long-acting sedatives and paralytics, how are we going to know that that patient's waking up before they actually wake up? It's another great thing. It's a tool that we're using here. We made it really important. It's a newer piece of tool, but it's great. It's small. The capnography, right? That end-tidal CO2 that we're measuring, that capnography on that tube. Does anybody know what we're going to see on that monitor? So we're going to see that little dip, and it's called a QRE cleft, okay? So we're going to see that, and what does that let us know? That their diaphragm, their diaphragm is starting to work. They are waking up. So we're paralyzing from the head down, and when it wears off, it's coming back up that way. So we're coming back from the feet up. So when we see that QRE cleft, we're knowing that their diaphragm is no longer paralyzed. It's working on its own. So that's when we need to start acting fast. Hopefully we never get to that point, but that is a definite sign. So that's why we need to be monitoring that. We need to be assessing. So how often do we need to be checking vital signs on this patient? At least every 5 minutes, okay? This is a critical patient. They need vital signs every 5 minutes. If you feel like there's something that's changed, no shame in hitting the button again, taking manual blood pressure, checking it yourself, okay? Don't always depend on the monitor. If you feel like it's not accurate, do it yourself. There's nothing better than manual, right? Alright, and then, depending on your county specific, what your agency, what they do for you, but they need to be on some kind of sedative. You can give them a sedative bolus when you redo the sedative, but they need to be on a drip more than likely. So when you get them to the hospital, they're going to put them on a drip. But we need to be making sure, when we go back to our assessments, which is not in here in part of the 7 Ps, but we want to be making sure on these patients that we're checking a good neuro exam prior to intubating them, because as a doctor, especially since we're going over trauma patients, the doctor's going to want to know how are they neurologically before you intubated them, before you sedated and paralyzed them. How were they? So we need to be making sure that's not in here, like I said, but we need to be making sure we're taking a really good neurological exam of these patients, because we need to know, did they have some kind of neurological injury, spinal cord injury, something, before we intubated them, and now we've paralyzed and sedated them for an extended period of time. And now doctors don't know what they were looking at before, so we need to know pre to that. So that's really important. All right. And then any questions? Anyone have any questions? Everybody good? All right, so let's just review just a little bit. So we've got 7. We did, what was the first one? Preparation, pre-oxygenation, pre-treatment, paralyze, protection, placement, and post-intubation management. So those are our big 7 Ps of our rapid sequence induction or intubation. And what was our 3 vital signs we need to look for, our big 3 for preparation? So our pulse ox, and we're measuring our heart rate, and our oxygen saturation, and then our blood pressure. So we're wanting to know, is it going up or is it going down? Are they compensating? And then our cardiac rhythm. Remember, we're wanting to know, is the medication we gave them causing them to have a different cardiac rhythm? Is something to do with their airway not being able to be maintained or protected by themselves? Is that causing something? Is there an underlying traumatic cardiac tamponade or something like that? Are we seeing something different that looks abnormal? Or, remember, this is a trauma patient, say they had a car accident. Was it a cardiac event? Did they have that EMI and it caused them to wreck? And now they're a trauma patient, but we're kind of masking that cardiac event. So, those are patients we want to do that 12 lead on to, right? Because we want to do a full assessment. Okay, and then we're needing how many IVs? 2. 2 IVs, if at all possible. We want 2. Because let's say that first one gets pulled out by that fire department, or that first one blows. We've all had that happen, right? I know I have. And then you don't have a second one. So you've got fluids going and you're needing to push medicine. So we need that second one, right? If we have an IO, it's good. It's a line of access. It's not as great as IVs, peripheral IVs, but some people differ for that. But IV is great, right? So we want to make sure that they're both good though, right? Secured and good. Flushing very well. Getting good flashback and flush. And then equipment. What's our equipment? So our BVM, our Yonker, our capnography for our tube. Don't forget, tube, not nasal cannula. And then we want a functioning laryngoscope, right? So we're checking those bulbs. I don't know about you guys, but we have tongue depressor in our airway bag. We have extra light bulbs taped to it because there's small little things that get lost. And so we just have them taped in there and we pull that out if we need them. But so often I feel that those little bulbs work their way loose. So we open up that and we're like, oh, the blade doesn't work. Replace the batteries. Well, it wasn't a battery issue. We just didn't have the bulb screwed in all the way. So make sure those bulbs are tight, not too tight. But usually, a lot of times I feel that's my problem when I check off the truck or bag, that's the problem, okay? So we want to check that it's functioning. And what are we doing? We're prepping. So if you want to, there's no shame in cleaning equipment, okay? If we didn't use it, clean it, put it back, right? So if you want to get different blades, if you want a Mac and a Miller, or if you want 2 different sizes, or if you want both, this is your equipment. Make sure it's organized though, so you can do both. Because if we fail on that intubation on our first attempt, we need to change something. We need to change the person who's doing it. We need to change the equipment, the position, something. Something's got to be changed. And then to the next one was our ET tube. So that endotracheal tube, we need the appropriate size. Remember we mentioned that it says typically men are 8, women are 7. It's not always accurate. You need to look at your patient. You might have that very small framed man. He's not going to be an 8. That's huge. Or you might have a bigger woman. Most of the time 7, 7.5 is accurate for most people. Okay, but you do have some of those larger people that you pass an 8 through and it works. I've done it, but they needed it. But I'm just saying, based off of your patient, not what's typical for a man and a woman, because not every man and woman is average. And then you need to prep all those medicines, right? We don't want the vials laying there. We want them drawn up. So we want those empty syringes, those needles, get that 18 gauge, draw that medicine up fast. We want those drawn up. And then we want to assess for a possible difficult airway. What was our mnemonic? It was lemon, right? Look, evaluate with the 332, and then Malin-Patty, obstruction, neck mobility. What did we say for neck mobility in trauma patients? So that C-collar, that backboard, that C-collar, that backboard, they're on it. Are they moving very well? No. We able to manipulate? No, and we don't want to. If they've got some kind of cervical injury, a spinal injury, we don't want to manipulate their neck. But do they have something else? Do they have kyphosis where they're not able to do that, right? So if they weren't able to move their neck, more than likely they're going to be difficult. But that 332, are we going to have time? Are we going to be able to do that? Are we going to be able to stick our fingers in that patient's mouth? No. Okay, if they're unconscious, we're not sticking our fingers in their mouth. But I don't know about you, but I don't want to get bitten either. So I'm not sticking my fingers in their mouth. But you can do, most of the time, you can do the 3 for the tip of the chin to the hyoid bone. You can do that. And you can do the hyoid bone to the thyroid cartilage. You can do that and kind of give you a quick gauge of what that is. Remember we said if you can't get 2 here, it may mean that they're very anterior on their larynx. So that could mean that they're going to be difficult. Not so much difficult, but just prepare yourself that they're really anterior. Sometimes that makes it difficult if their anatomy is anterior. We're not able to visualize it as good as normal, okay? And then we did preparation. So that's all of our preparation. And then we did pre-oxygenation, right? So we want 100% oxygenation because they're going to desat during that intubation. So we want that up as high as possible. Some people desat more than others depending on their situation. Okay, so if you've got that smoker, for instance, so their oxygenation, probably their saturation levels are probably not that high anyway, and now they're in some kind of traumatic event and we're having airway compromise, they're going to be lower anyways. Okay, so we want to get them as high as possible for the chance that they're going to desat fast because we need to be fast. We want to be in and out in 30 seconds. We want to visualize, get that tube, drop that tube in 30 seconds. That's what we want ideally. Doesn't always happen, but remember we're going to be pushing these medications, okay? And then we got pre-treatment. We talked about our pre-treatment. Most of our pre-treatment medicines were for what? Our ICP, intracranial pressure. So those patients with head injuries, right? So we want to push those medications. And then we did paralyze. We've got paralyze next. So we talked about where we're going to give our sedatives, right? And our sedatives and our paralytics. So we've got etomidate, Versed, ketamine, propofol, more hospital setting. And then we had our succinylcholine and our rocuronium. Remember our big succinylcholine was the contraindication, malignant hyperthermia in the Lumbee Indians. Okay, we're not always going to know that. Sometimes we might look up and find it out. Hopefully not after we push the medications. And then we got protection. Remember we talked about celiac and the cricoid cartilage. All right, and then we have placement of our ET tube. Passing that, direct visualization, there's nothing better than that. Okay, okay? And then we're going to check to make sure we've got it. So we're going to do the epigastric and then listen bilaterally to our lungs. Hopefully we're in there. If we're not and we're in the right main stem, sometimes we can back it out and it's perfect, okay? And then we want to secure that tube. If we've got that airway, we don't want it going anywhere. So we want to secure it. Commercial device, tape, whatever your agency has. And then at that point, if you were doing the cricoid pressure, you can release that. And then post-intubation, long-acting. So we want to think about long-acting paralytics and sedatives. Remember lorazepam, vecuronium if you have them, whatever you have for long-acting. Okay, most people have short-acting and long-acting. And then we want to initiate those mechanical ventilations. So we are bagging them with the BVM, and then when we get them to the hospital, we're going to hook them up to the ventilator. Okay, and then we want to worry about long-term sedation and paralytic, right? So the hospital's going to have that. Most of our agencies, we're just doing short-term. We're going to do that. So what we're going to do is we're going to get into groups, and we're going to prepare and talk about this with ourselves, okay? So you're going to do the 7 Ps, and if you think about these, if you look at your drug-assisted protocol for the state of North Carolina, the 7 Ps are in there. It just doesn't say preparation, paralyze, post-intubation, but they're written in there. That's all word for word in there. We're just kind of breaking them out to kind of help you remember the 7 Ps, because this is an emergency situation and our adrenaline's going, and we're human, so we don't always remember. So we're going to get into our groups and prepare our equipment and go through the motions. And if you have questions along the way, you can ask. But I really hope you guys have enjoyed this class and hopefully taken something away from it. And I hope that everybody has a good day. All right? Thanks. See you guys.